Assalamu alaikum warahmatullahi wabarakatuh. So we'll continue the previous class. Okay. So we have examined the lungs. Coming to the peripheral stigmata of pulmonary disease. So what you will see in peripheral? Hypertrophic pulmonary osteoarthropathy, clubbing with hypertrophic, with pain in the wrists and ankles, with hypertrophy, with the subperiosteal deposition of bone. So that you can see. So clubbing is a very important sign in cardiovascular disease. Okay. Unilateral wasting of the thenar eminence unilateral wasting. So in apical lung tumors involving or compressing the brachial plexus in the axilla. So pan-coast tumor that is called. So in those patients, when there is compression of the brachial plexus, you can have a wasting of this thenar eminence. And if there is generalized wasting, that is a case of severe pulmonary disease. Okay. So some of the skin manifestation of respiratory diseases. So I will just zoom it out. Allergy and anaphylaxis. You can have urticaria, laryngeal edema, okay. AV malformations, you can have telangiectasia, dermatomyositis, heliotrope rash. These are diseases where the lungs can also be involved, no? That's why. Eczema, you can have allergy, no? Red bumpy rash becomes scaling and dry. Illicit drug use, scarred vein of forearms. Lung cancer, palpable nodules can have. Neurofibromatosis, cafe outlet spots. Paracoccidioidomycosis, okay. Pneumonia, mycoplasma actually. So you can have a erythema multiforme type of rash. Pneumothorax, you can have subcutaneous emphysema. Psoriasis, you can have plaques. Rheumatoid arthritis, they can be involvement of lungs. So sarcoidosis, erythema nodosum, okay. Scleroderma, telangiectasia, sclerodactyly. SLE, malar rash, discord lesion. Tuberculosis, erythema nodosum, okay. Erythema nodosum. Tuberculosis, chagrin patches, vasculitis, peripheric rash. So these are all diseases where lungs can get involved. What are the diseases? Allergy, and you will have a pointing skin manifestation of that. Allergy, anaphylaxis, AV malformation, dermatomyositis, eczema, illicit drug, lung cancer, neurofibromatosis, pneumonia, mycoplasma erythema multiforme, pneumothorax, psoriasis, rheumatoid arthritis, sarcoidosis, scleroderma, SLE, tuberculosis, tuberculosis, vasculitis. Okay. Moving forwards. Asterixis. So you know this before going into the altered mental status, patient will have flap of this Asterixis flap we have discussed now. So because of carbon dioxide retention, patient will have hand sign now, Asterixis. You can see. Before going to pulmonary encephalopathy, I am saying this from my side. Due to lung, there is encephalopathy. Due to pulmonary encephalopathy, you can give the name to pulmonary encephalopathy. Okay. Now, these are the signs. This is a very important chart. Okay. In hands, what all you can see? If there is tar staining, association, smoking, the patient can be a smoker. That's why there is staining of tar in the hands. Clubbing, so many respiratory disorders like subperitoneal lung disorders of lung, or carcinoma of the lung, or even severe COPD or AV malformations, pulmonary AV malformations, you can have clubbing, no? So that you can see. Tar staining you can see in the hand. Clubbing you can see. Peripheral cyanosis you can see in the hands because of hypoxemia. Small vessel wasting, okay. Pan-coast tumor, remember, wasting of thenar eminence. Asterixis, carbon dioxide retention. Okay, you should see all these things. Tremors the patient can have in anxiety states. Koilonychia is spoon-shaped nails because of iron deficiency anemia, that points to iron deficiency anemia. Leukonekia, white nails because of protein deficiency. Like in pleural effusions, they will lose the protein in the pleural fluid that will get aspirated, no? So leukonekia that patient can have. Raynaud's phenomena, so that points to some connective tissue disorder where the lungs can also get involved. So these all you can see. Tar staining, clubbing, most common these two, and small vessel wasting, Asterixis, Koilonychia, nail, leukonekia, Raynaud's phenomena. Okay, these are the hands sign. So what are the signs you can see in face? So in face, central cyanosis, which points towards in the lips, oral mucosa and earlobes, okay, particularly in lips. There will be bluish discretion, paler, chronic anemia of chronic disease, Horner syndrome, PAM, remember PMA, okay, and pharyngeal injection, nothing but congestion of pharynx. So that can be due to some viral infection or bacterial infection. And remember one thing, HIV infection, very important. In particularly in young patients, they are coming with sore throat. Okay, you should rule out in particularly in Western countries, they where they are, all those things, they will have multiple sexual partners and all. So any young patient coming with a sore throat, they will have a HIV serology, because it can be a initial you call no, there is primary infection of HIV will have some syndrome. Primary HIV infection, it can indicate sore throat and generalized lymphadenopathy in young patients. Malar flush, both cheeks, that can be true. SLE, as well as you can see in mitral stenosis also. In mitral stenosis, it is because of congestion. Okay. In SLE, it is erythema. It is a rash. But in mitral stenosis, it is because of congestion. Okay. Malar rash, SLE, as well as in mitral stenosis. Parotid enlargement, uvoparotid fever. Sarcoidosis, in sarcoidosis, you can have parotid gland enlargement. Microstomia, meaning small mouth, fish-like mouth, you can have in systemic sclerosis. Xerostomia, dry mouth, you can have in Sjogren's syndrome. So connective tissue disorders which involve the lung. Okay, Sjogren's syndrome, dry mouth, xerostomia, systemic sclerosis, fish-like mouth, microstomia. Oral telangiectasia, hereditary hemorrhagic telangiectasia, HHT. Okay, these are all face signs which are seeing in face and in mouth. Okay, parotid enlargement, mouth. Okay, you can have this nasal crusting. Oh, this is very important. Nasal crusting can indicate granulomatosis with polyangiitis. Granulomatosis with polyangiitis, a type of vasculitis which involves the lungs. So they will have nasal crusting in this patient. Saddle nose leprosy. Okay, saddle nose deformity, you can see in leprosy patients also, and also you can see in granulomatosis with polyangiitis. So in two things you can see in granulomatosis with polyangiitis: nasal crusting and saddle nose. Nasal crusting and saddle nose. So these are the signs. These are the signs which you can see in the face. Now, so lymphadenopathy you can have, it can indicate infection, inflammation, or malignancy, tuberculosis or viral or bacterial also. Elevated JVP, jugular venous pressure, that will indicate right heart failure or pulmonary. Suprasternal notch scar, previous mediastinoscopy. Supraclavicular scar, phrenic nerve rush, tuberculosis. Okay, that is sign. Mainly remember lymphadenopathy and neck parotid enlargement. Also you can remember elevated JVP. Okay, then in legs you can have edema, that indicates either due to hypoproteinemia or right heart failure in chronic lung disease patients. Edema you can have. Erythema nodosum, which is prominent on the shins, lower limb shins. You will have, no, you just go and watch the picture of this on the so in tubercular disorders you will see this erythema. Tubercular disorders, erythema nodosum, tuberculosis and sarcoidosis. Unilateral leg swelling, if it is there, you suspect venous thromboembolism. You should also suspect, very important in this patient, this is also very common. Dull sign, what is dull sign? You see in emphysema, darkened and thickened skin on lower thighs and elbows. Dull sign, darkened and thickened skin, dark and thick skin in lower thighs and elbows. Lower thighs and elbows you see in emphysema. Just remember this dull sign. These are common edema of one limb or both limbs or nodosum, and this is also important lymphadenopathy and raised JVP. Okay, cyanosis, pallor, horners, pharynx, malar flush, parotid enlarged, mouth, oral degeneration, nasal deformity and nasal crust. Tar staining, clubbing, small vessel wasting, Asterixis, tremor, colonychia, leukonychia, Raynaud's phenomena, sclerotary. All this thing you should see. Okay, you should see in patients. This all we have discussed, no? Oh, something happened. Now, okay. So in skeletal and muscles, what you can have in respiratory patients: hyperscoliosis, lateral, and they will have some mechanical disorder. That's why they will have this difficulty in breathing. Hyperscoliosis, ankylosing spondylitis. So in patient with ankylosing spondylitis, you can have progressive upper lobe fibrosis. Ankylosing spondylitis, rheumatological disorder involving the lung. Rheumatoid disease, you can have pulmonary nodules, fibrosis, fibrosing alveolitis, pleural effusion. So these are connective tissue disorder involving the lung. So ankylosing spondylitis can have upper lobe fibrosis. Rheumatoid arthritis can have effusion, fibrosis, nodules. Okay. So never ever miss cardiac examination in patients with respiratory disease. Cardiovascular signs, most signs in respiratory disease relate to the development of right heart dysfunction or pulmonary hypertension. One should also look for signs of deep venous thrombosis as the origin for pulmonary embolism. So always examine the limbs in patient with respiratory disorder, chronic respiratory disorder. So what are the cardiac signs which you can see in these patients? Pansystolic murmur of right aspiratory regurgitation you can hear. Diastolic murmur of pulmonary regurgitation you can hear. These are all signs of pulmonary hypertension. Okay, split second heart sound, remember A2 P2. So you can hear separately. Triple heart sound, you can hear triple heart sound, split second heart sound. Why? Because because of pulmonary hypertension there will be delayed closure of the pulmonary valve, and because there is no hypertension as such in the left ventricular, so there will be early closure of the aortic valve. So there will be gap between A2 and P2. Okay, that's why split heart sound you can hear in patient with right heart failure or severe pulmonary hypertension. Loud pulmonary component of second heart sound. So second, remember, just S2 will be loud. That is due to pulmonary hypertension. S2 will be loud. There can be split A2 P2. Okay, normally there will be gap, but you can appreciate this gap in hypertension patients. A right ventricular third heart sound. Okay, triple murmur you can have because of volume overload. Elevated jugular venous pressure you can have because the jugular vein is direct. Jugular vein they will reflect the right atrial pressure. No, so when the right atrial pressure is high because of pulmonary hypertension, so there will be elevated JVP. Prominent A and B waves in JVP. Right ventricular parasternal heave because of right ventricular hypertrophy you will have. So these are all the auscultatory and palpatory findings which you will have. And systolic murmur of tricuspid regurgitation. Okay, split second heart sound, loud S2. Okay, this is A2 P2, this is S2. Right ventricular third heart sound. Okay, triple murmur. Okay, triple murmur, triple heart sound you can hear. Elevated JVP. This is palpation. No, this is palpation. Right ventricular. This is auscultation. Sorry, and this is palpation. Remember all these things, why they are happening? They are happening because of pulmonary hypertension. Okay, then you will remember all these signs. That's about inspection. Coming to palpation. Palpation, you palpate the neck for any lymphadenopathy. Tracheal deviation best assessed at the suprasternal notch. Carotid pulsation, carotid artery, palpate the carotid artery. Okay, but remember, before palpating the carotid artery, first auscultate the carotid artery. If there is no what do you call murmur, no, you will not say that as murmur. If there is no rush you hear in the stethoscope, then only you palpate the carotid artery, because there can be some emboli which will be there in the carotid, and you will press that, and that will get dislodged into the brain. So before palpating the carotid artery in this patient, just auscultate. Okay, so lymph nodes you will see, trachea you will see, carotid pulsations you will see. In chest you will see areas of pain and tenderness which will indicate refracture, cuff trauma, vertebral collapse, lumps, particularly in female patients, breast lumps. Okay, chest expansion is important. So unilateral reduced chest expansion, diseased hemithorax, reduced hemi-expansion you will see in pleural disease. Okay, significant effusion, fibrothorax, structural immobility or defect, thoracoplasty or rib fracture, diaphragmatic paralysis. All these things we call one side reduced expansion of the chest, pneumothorax. Okay, chest sound, that is called as, so palpating the chest sound is vocal fremitus. Those chest sound if you hear with a stethoscope, that is vocal resonance. Okay, that we will see in auscultation. The chest sound is vocal fremitus. So vibrations transmission along the chest wall. So remember, because there is air, and these vibrations will be dampened by that air, so normally you will not have that vocal fremitus. But when the alveoli are filled with some air, pus, some fluid, some blood, then transmission will become better, and you can hear, you can palpate this vocal fremitus. So decreased vocal fremitus you will see in diseased hemithorax. So something which is coming in between the pleura and the chest wall, either it can be air, or it can be fluid, or it can be pus. So that will reduce the transmission of the lungs to outside, so you will see decreased vocal fremitus. Increased vocal fremitus is in consolidation, so lungs are filled with fluid, so vibrations can pass easier. Apex beat you will palpate for apex beat. So these are there, but very rarely we palpate this we will see. Okay, percussion to bahut kam bhai. Ventricular heaves you can see. Okay, that indicate ventricular hypertrophy. Valvular thrills you can see, strong murmurs. Remember these things, no? Palpate with the fingertips, and thrills with this part of the palm, and heaves with this heel of the palm. So this is for apex beat, this is for thrills, this is for heaves. Okay, so this is important actually. Cardiac palpation. Percussion very rarely we do in examination. So in percussion, stony dull percussion, something which is coming in between the chest wall and lung, that will reduce that sound. Okay, so pleural effusion, hemothorax, empyema will reduce. Stony dull, okay, something which is coming that cause stony dull percussion. So air is not there, no, so that's why in collapse and consolidation you will have dull percussion. Hyper resonant, more air is there, so you see pneumothorax. Diminished area of cardiac dullness, what that means? That means air is present in between the parietal pericardium and visceral pericardium. That's why there is diminished area of cardiac dullness normally. Okay, stony dull area, so some fluid is there, pericardial effusion you will see. So this is not actually seen. The most important examination which we do in respiratory is the one examination, if we say, which we do in respiratory clinical examinations, auscultation. Auscultation is very important in respiratory examination. That's why we should know auscultation. Very good. 3 general categories of sound that can be listened for. Remember these general points. So first you should listen for breathing sounds, normal breathing sounds, then pleural sounds, then quality of transmitted voice, nothing but vocal resonance. Vocal resonance, you can divide this into broadly into 3. 3 is nothing but, one is breathing sounds, second is pleural sounds, third is vocal resonance. Remember this one. Now we'll go according to that. So breathing sounds, normal breathing sounds, normal lung, also known as vesicular sounds. Okay, so remember, normal inspiration, then expiration. Okay, these are heard over most of the lung fields. The large volume of air in the lungs dampening the transmission of sound. So the air which is entering the large airways, no, that will have a very harsh quality. So because there is air and there is lung parenchyma, this air and lung parenchyma will dampen, they will reduce, they will soften these sounds, and the sounds normally which we auscultate, no, that becomes vesicular breath sounds because of this parenchyma and air which is present in the lungs. So what is the quality? They are longer and louder on inspiration than expiration. They are longer and louder on inspiration than expiration. Continuous in nature, louder towards the bases, and are quieter and low pitched than the bronchial breath sounds. Okay, bronchial breath sounds. Remember the quality of vesicular breath sounds. Why? They are produced by turbulent airflow through lobar and segmental bronchi. Breath sounds may be globally reduced in COPD and severe asthma. Yes, because there is obstruction in the airways. So this is one point. If you hear less breath sounds, you can hear in COPD and severe asthma patients, reduced breath sounds globally. Now regional reduction in normal breath sounds, regions of quiet sounds, they indicate partial obstruction of the bronchus to the region, or an underlying large bulla in emphysema, pulmonary collapse, or pleural effusion. These all can be the causes. So from the lung to the chest, up to the chest. From the lung you start from the airways. So partial obstruction of the bronchus, this is the one thing. So to that region there is less air going on. So when no other signs may be found, only just some area you are getting less vesicular, less intensity of breath sound, that means that partial obstruction to the bronchus can be there. Second is, there can be a bulla in patients with emphysema where you are getting less breath sounds. Third is collapse due to obstruction of some airway. The lung is collapsed at that part, so you will get less breath sound. Fourth is pleural effusion. Okay, so in emphysema patient, as usual you will get less whole. Okay, but at some region, if you are getting decreased lung sounds, you can think of partial obstruction of bronchi, bulla in emphysema, pulmonary collapse, bulla, and pleural effusion. Okay, regional reduction in breath sounds. Now coming to the bronchial breath sounds. Bronchial breath sounds are physiological and pathological. Physiological, you will hear it on the trachea and large airways where there is no lung parenchyma present, no, to filter the breath sounds. Pathological, if they are present over those area where you hear vesicular breath sounds. Okay, this can be heard over the trachea and large airways in areas where there is little or no lung parenchyma. You will see interspersed between the airways in the chest wall. And what is the quality of these sounds? there will be a gap between the inspiration and expiration, and duration will become similar like this. This is inspiration, this is expiration, and there will be a gap. There will be a gap. So this is the character of respiration in this patient. So these pathological bronchial sounds, they are called pathological when they are heard anywhere other than as just described, indicates a loss of alveolar integrity such that large airway sounds are transmitted unchanged because there is no lung tissue which is dampening that. Okay, so where you can see all this in lung collapse, you can see, okay, the parenchyma is lost. Particularly most important thing is consolidation. First point which should come in a pathological bronchiolitis, consolidation can be due to infection or due to infarction. Okay, so consolidation conducts the sound, there is no dampening, and bronchial breath sound can be conducted very easily, so you can hear bronchial breath sounds in consolidation. Pneumothorax, you can have bronchial breath sounds occasionally in the upper region. Just remember in this consolidation, very important, consolidation. So anything like collapse, consolidation, cavitation, pneumothorax, in all these things you can hear bronchial pathological bronchial breath sounds. In all these, consolidation is the most important thing. Now in breath sounds only, there are adventitious breath sounds, meaning abnormal breath sounds, that can be classified as crackles, wheeze, stridor. We will see in the coming slides. So crackles, also known as rails and crepitations, these are short non-musical sounds and are described as fine or coarse. They can be fine or coarse. Fine or dry crackles, they sound like a velcro, you know, no, you just open your shoes and just that will stick, that is velcro. Okay, the sound when you open the that velcro, you will have some sound that is like that, they will resemble. They sound like a velcro and are produced when diseased distal airways, this is important, and alveoli snap open. They are heard only during inspiration. Classically occur usually bilaterally over areas of pulmonary fibrosis, often late and very fine. That is one. Coarse or wet crackles, fine or dry crackles, coarse or wet crackles. By the name only you can identify. Generated by fluid filled alveoli. They are heard in both inspiration and expiration. They are louder than fine crackles. Okay. Where you will see this pulmonary edema, you will have both inspiration and expiration. Pneumonia, bronchiectasis, secretions will be there. Secretions will be blocking, so you will have that. But occur in any situation where there is excess fluid in the airways. Pulmonary edema, pneumonia, bronchiectasis, where there is excess secretion or some fluid, so you will have that wet crackles. Okay. Coming to wheeze, important repetitious sound. It is a high-pitched continuous sound with a whistling quality, always more than 80 millisecond. Okay, it is generated by turbulent air traveling through the narrowed small airways. Remember, narrowed small airways, persisting even after coughing. This is important because these 2 points are helpful it from differentiating from rhonchi. So these are produced because of narrowed small airways and they persist after coughing. They are more pronounced on expiration. Because the negative intrathoracic pressure generated during inspiration helps to maintain the airway patency. Now there can be two types of wheeze. Remember these points: narrowed small airways, persist after coughing, more pronounced on expiration. Expiratory wheeze. Okay. Polyphonic wheeze. So different varieties of wheeze you will see in acute asthma. Monophonic wheeze, single airway obstruction, you will have monophonic wheeze that can be due to some bronchial obstruction like by a tumor. It can be benign or malignant. So this is important. Differentiate rhonchi from wheeze. Rhonchi are low pitched wheeze like sounds. They are not actually wheeze. Because of larger airways, they have a gurgling quality or rattling quality. These are due to secretions and they disappear after coughing. Wheeze are because rhonchi are because of secretions in the large airways. Secretions blocking the large airways. Secretions blocking the large airways will cause wheeze-like sounds. And these rhonchi now, these are present both during inspiration and as well as during expiration. Wheeze-like sounds, if you cough, that will disappear. This is very important sign. Coughing will, because that secretion will go, so rhonchi will disappear. That you think, remember. So that is about wheeze, rhonchi, crackles. Coming to stridor. We are discussing it, but unless and until you hear these sounds, now you go and just watch the videos of these things, you will not see these in patients, you will not recognize these in patients. Stridor. What is stridor? A high-pitched, loud. It is an continuous inspiratory sound which indicates upper airway obstruction. Urgent investigations and urgent management is required for this stridor. Inspiratory stridor, remember like this, inspiratory stridor, musical type of sound. What is squawk? Squawk or squeak? This is mixture of short wheeze and crackles. Okay, these are heard at inspiration. So mixture of wheeze and crackle is nothing but squeak. Short wheeze, end of inspiration. Remember, wheeze is more pronounced in expiration, but this is in inspiration. So inspiratory wheeze plus crackles in the middle of inspiration, that is nothing but squawk or squeak. These are seen in hypersensitivity pneumonitis and less often in interstitial lung disease, bronchiectasis, and pneumonia. Classically seen in hypersensitivity pneumonitis, quack. That's about breath sounds. Now coming to pleural sounds. What are the pleural sounds? Anything which interrupts the normal smooth gliding action of the parietal pleura over the visceral pleura will create friction between the two surfaces. That friction causes sound. This can be heard as a pleural rub, a dry rubbing or crunching sound during respiration, often likened to the sound made when walking in a crisp snow. रेती के अंदर चलो, रेती के अंदर चलने के टाइम जो आवाज आती है, या that small stones which are used for build the buildings now. So if you walk in that, or if you walk in a collected ice collection, the sound which comes, it is likened to that sound, or creaking of leather. The pleural crunchy sound, it is a crunchy sound. Crunch, this is easy to remember. So it is a crunchy sound, that is pleural rub. What are the causes? Pleural inflammation or tumor or pleuritic type of pain. Okay, anything causing pleuritis, pleuritic type of pain, you can have pleural rub. Pleural rub is a important sign of pleuritis. So that is about, so breath sound over in breath sounds, vesicular breath sound, bronchial breath sound can be pathological bronchial breath sound. Then adventitious sounds, adventitious breath sound, coarse, fine crackles, core crackles, wheeze, expiratory, wheeze is expiratory. Okay, polyphonic wheeze, monophonic wheeze, differentiate it from rhonchi. And then stridor, inspiratory stridor, and then squawk. Okay, short inspiratory wheeze along with crepitations. Rhonchi will disappear with coughing, and it is because of secretions blocking the large airways. Wheeze is because of narrowing of small airways. The wheeze will not disappear with coughing. Vocal resonance, it is nothing but auscultatory equivalent of tactile fremitus. Normal voice has muffled quality while being translated clearly through consolidated lung. So vocal resonance in consolidated lung, you remember vocal fremitus is increased, so is the vocal resonance. Vocal resonance will increase in consolidation. And when the vocal resonance is decreased, something which is present in between the lung and wall will decrease the vocal resonance, whether it be air, fluid, or solid material. So this is a important conclusion. Differential diagnosis of respiratory disease based on physical findings. Most important physical findings is auscultation, we will know. So remember, this has infiltration, and atelectasis is nothing but collapse. Atelectasis is nothing but collapse, fibrosis, effusion, pneumothorax, airway obstruction. So in infiltration nothing but consolidation. Infiltration, chest movements will be asymmetric, motion impaired on the side of infiltrate, percussion will be dull, vocal fremitus will be increased, bronchial breathing, because it is a consolidation, bronchial breathing, you will have crackles, you can have, okay, but there will be no displacement of mediastinum. Remember always the displacement of trachea in respiratory. While seeing the lungs, you should also see the trachea. Atelectasis is nothing but collapse, asymmetric motion markedly impaired on the side of atelectasis if large, percussion will be dull. Fremitus, reduced atelectasis caused by airway obstruction, increased atelectasis caused by airway compression. So you important is breath sound. Auscultation is very important in all this. Okay, auscultation. You will have reduced lung sounds because of collapse. Crackles you can have because airways will open in inspiration. Bronchial breathing may be audible. Okay, because on consolidation and collapse you have bronchial breathing. Now here there will be displacement of trachea towards the site of collapse. Fibrosis bilateral, impaired symmetrically, slightly dull, reduced. You will have crackles, reduced lung sounds, no displacement of trachea. Pleural effusion, asymmetric, dull, reduced vocal fremitus, absent breath sounds in the setting of small pleural effusion, pleural friction rub. In initial phase, you will have this pleural friction rub, or small effusion will have pleural friction rub. You can auscultate this. And in pleural effusion, trachea is deviated away from the side of effusion if it is large. Pneumothorax asymmetric, percussion hyper-resonant, absent, bronchial breath sounds absent, with tension pneumothorax away from the side of the lesion. Airway obstruction symmetrically increased chest movements. Work of accessory respiratory muscles. So airway obstruction can be large airway obstruction, or it can be COPD or asthma also. Okay. Percussion will be normal. Vocal fremitus can be reduced or unchanged. This is important. This point. These 2 points. Wheeze, rhonchi, prolonged expiratory phase is a sign of airway obstruction. There will be no displacement. So this is a table which shows the differential, how to differentiate differential diagnosis based on physical findings. By this, we conclude the whole chapter of cardinal manifestations of respiratory system. Inshallah, by the next video, we will start the cardinal manifestation of cardiovascular system. May Allah accept our efforts. Allah ke liye karna hai bhai. We'll meet in the next video. Thank you for your listening.